Hello, my name is Kat Loftus, and welcome to episode 37 of A Slice of Pie podcast, where we feature the people, places, and events in Georgetown County. Since we just finished the month of October, I wanted to bring on a guest who could tell us about all the advancements and improvements we have for breast cancer patients, all the improvements we've had in mammograms, early detection, treatments, and all the options that breast cancer patients have these days and how it's improved vastly in the last 50 years. So our guest is Dr. Craig Brackett. He is our surgeon here who specializes in breast cancer. He is an expert, he is highly trained, and he knows everything there is to know about early detection, treatment, care, and surgery of patients that have been diagnosed with breast cancer. You will love this episode. He is entertaining. He has a lot of fun things to say. He has a lot of important things to say, and he really cares about his patients and is dedicated to doing the best he can to save your life. So sit back and enjoy episode 37 of A Slice of Pie podcast.
Ready? Hi, Craig.
I can't.
It took us a while for this to work.
Well, you're the pro, so we're just trying to figure it out.
Well, we didn't have any 12-year-olds around to help us, so we did the best we could to figure it out.
Yeah, no kidding.
Anyway,
Right.
Welcome to my podcast. Have you ever been on a podcast before?
No, this is my first podcast.
Well, I'm so glad it could be on A Slice of Pie. So thank you for joining us. So, Craig, A Slice of Pie podcast highlights people and places and events in Pawleys Island, Georgetown, and Murrells Inlet about the things we do in Pawleys Island and things we'd like to celebrate here. So thank you for joining us.
Sure, glad to do it.
So the reason why we're having Dr. Craig Brackett on this week is Dr. Brackett is a breast cancer surgeon. So if you get the diagnosis that you have breast cancer, Dr. Brackett is the one that's going to save your life and be your hero. So we wanted to talk about what you do and how you help people that are diagnosed with breast cancer. But before we start, would you just tell us a little bit about yourself, where you grew up, where you're from, and where you went to school?
So I grew up in Charleston and went to Portugal, then Clemson University, and then went to MUSC in Charleston and did my medical school training there, and then did my surgery in Augusta. I married Amy during our sophomore and junior year of med school, and we have 3 beautiful children, all who went to Clemson.
Was Amy in Augusta?
Yes.
What was she doing there?
She was a physical therapist. She actually ran a neuro rehab hospital.
Okay, cool. Okay, keep going. So then so from Augusta, where did you go?
We went to Charleston for 2 years, and then the opportunity came to come to Georgetown, and I started there. And then in the mid-90s, I was at a meeting, actually the first multidisciplinary meeting from the Mayo out of Jacksonville and Amelia Island, and it was the breast cancer multidisciplinary meeting, and that kind of lit the fire in the mid-90s.
Well, wait a minute. But you were doing surgery before that.
Oh, yeah. I did general surgery for about 15 years.
Yeah, because you operated on me when I needed a little hernia repair.
Yes, ma'am.
And it was shortly after that I think you switched over completely to breast cancer.
Well, I started developing a program in the mid-90s and still did general surgery. And it wasn't until about 2000 or so that I just went full-time to take care of breast cancer patients.
Right. Okay. So you met Amy in Augusta, and then what year did y'all get married?
1987. So we'll be 40 next year.
Congratulations. That's a long time.
Mm-hmm.
What do you attribute?
No, 85, sorry. 87 is when I graduated from med school. But yeah, next year will be our 40th anniversary.
So what do you attribute your successful marriage to?
1, our faith. 2, our commitment to the marriage. 3, our wonderful children. And, those 3 things have kind of binded us. We've been on this journey together, and she's obviously the backbone of the family, as you are.
Well, I think you come to rely on each other after a while. And people have got to remember that nobody's perfect in the marriage.
Yeah.
And everybody needs to forgive everybody. So there's a lot of forgiveness and a lot of laughter that needs to go on.
Yes, and we do very good with all that.
Good. Well,
a good team.
Yeah. I am so excited I could speak to another Clemson Tiger. So glad we have you in our area. You live around a couple of Clemson Tigers up there in your neighborhood, don't you?
We do. We got well, Mr. Gleaton didn't go there, but he's a big Tiger fan.
He is a big Tiger fan.
Then Marshall behind me,
Mhm.
and I think a few others. But we also have some Seminoles and some Ole Miss guys, and of course a Gamecock or two.
Yeah. You know, when I first moved here and I wanted to just talk big about the Clemson Tigers, I quickly learned that I was in the minority.
Yes.
There was many more Gamecocks here, and I had to keep my mouth.
Let's not get distracted now.
Anyway, but we love our Gamecock friends. Okay.
We do.
So my next question is, Craig, I kind of interrupted you. So you're talking about your children. So would you tell our listeners about your children for a second, please?
Well, we have three, Ben and Katie and Will. They've all graduated from Clemson. Ben is married and has a little girl. Katie's married and has a little girl. And Will just got out from Clemson in May, and he's working in Charlotte. So all three graduated from Clemson. Katie's a nurse. Ben and Will are in construction science. We have a very close family.
Yeah, you do. And beautiful grandchildren.
Yes, ma'am.
That's pretty cool. Okay, so next question. Why did you decide to go to med school?
Well, my dad was a doctor. He was the first nephrologist in the state of South Carolina. And believe it or not, there was a show in the 70s and 80s called MASH.
Uh-huh.
And that was my probably favorite show ever. And just loved the operating part of that. And that kind of lit a fire under me. My dad never pressured me, but I knew from a very young age that I was going to be a physician. I never even entertained doing anything else. The question was whether I was going to do medicine or radiology or surgery.
Now, and then how did you decide to go to specialize in surgery?
To me, there's like this book called The Thin Red Line.
Mm-hmm.
And there's a red line when you walk in the operating room, and only certain people can go across that line because it's a sterile environment. And then I always thought that it was a huge privilege to operate on another human's body. And I thought that was the epitome. And obviously all doctors are important in what they do, but that was the thing. I just thought that was the most important thing or you could achieve was to have somebody trust you to operate on them.
Yeah, it takes a lot of knowledge and a lot of confidence to be a surgeon, correct?
Which is why we have very funny personalities that we have to mature into. But you have to be confident because it's every day in the OR is a different day. You have to believe in yourself and your skills. And I think it's really important that you have mentors that really train you and push you to be very good at what you do.
I'm always amazed at when surgeons are getting down into tiny veins and arteries, how you even see anything, or how you can know that this goes over here and this part goes over here, and how you can identify all the different parts.
Well, that's what anatomy was for. And there's some consistency in it. And so you just by sheer repetition, you get to a very good understanding of the body's human anatomy, and what structures go where. And because I've done vascular, GI, thoracic, so you got to know all the different components and where they're hooked up and all that kind of good stuff.
Yeah, I think my other mystery of something I don't understand about surgery is when you have to clamp something off and keep the patient's heart going while you're operating on them, how to keep them alive while you're operating. That's why I don't understand.
Well, that's what bypass is for.
Mm-hmm.
So when we do like open heart surgery, and they have some more sophisticated stuff today, but when you do open heart surgery, you actually have a machine that circulates oxygenated blood to the brain, the kidneys, the liver, and all that, so you can fix the valve or do the coronary artery bypass and graft.
Yeah, amazing. It's all very, very
absolutely.
Okay. So I want to go back to your personal life for just a second. How did you end up in Pawleys Island?
Well, I was actually at a laparoscopic course in Cincinnati and met a surgeon, and he recruited me to come here. And so, and I was looking for an opportunity where I could use all my skill. I was the 11th surgeon to join Roper in 3 years. So we went from 10 to 21 in 3 years, and just, I felt like I was not using my skills down there. And so I wanted an opportunity where I could go and do all the things that I had trained to do.
So do you remember the surgeon that invited you down here, that kind of recruited you?
Yeah, Roger Altoff.
Oh, I do remember him. Yeah. So then you came up to well, then it was called Georgetown Memorial Hospital, right?
Right.
Okay. So how many surgeons then when you joined the staff?
There was 5, and Dr. Forrester was the senior surgeon, who was a wonderful, wonderful man, and had a lot of respect for Jim. And they were older, so they kind of eventually all retired. And so we built a practice. We don't need to get into all that, but in the mid-90s, I think the good Lord put a fire in my heart to go do what I'm doing now.
So, what you said mid-90s is when you started specializing in the breast cancer surgery?
Well, just started really beginning to understand it, because it changed so much in the 90s. When I was training, all we did was mastectomies, and there wasn't a lot of chemo regimens. There wasn't a multidisciplinary approach. And then all that began to change, and the rapidity of growth between the 90s and like 2010, the amount of growth that happened in breast cancer in that 10 or 15 years was insane. And so I joined the American Society of Breast Surgeons. I go to Miami Breast every year, the multidisciplinary meetings. Actually went to the board, and I called it my Field of Dreams speech, to build a cancer center. And then I put together our tumor board.
You went to the Tidelands board?
Yes, ma'am.
Okay.
So I did a presentation about what it would mean to build a cancer program here. And this was like in 2000. And had great support from Bruce Bailey and GP Ford, Mr. Ford, when he was still alive.
Yes.
And
Papa Jeep.
Papa Jeep. And all those guys were great. And I think Mr. Ford fell asleep while I was talking, because I could talk about breast cancer for a long time, but really had a lot of
You had already made a believer out of him. He already was on board.
Well, McRoy Skipper was there. There's just some good people.
Yes, yes.
And we had a dream. We had a vision of what we needed to do, and got the support. And then we were able to recruit. We started a radiation oncology program, recruit really fine medical oncologists. We already had great pathologists, and we already had a very strong foundation in radiology. And that's all grown. We have just super specialized in each one of those specialties now. So it's kind of all come together and come to fruition for us, And I think one thing I want to tell you, I read an article like in the early 90s when I joined the American Society of Breast Disease, and it said that 75% of women with breast cancer are treated in their community. And it's meaning they weren't traveling places. And I said, well, we need to earn the right to do that so women don't have to travel.
Right.
And we've clearly done that. I get a lot of credit, but I'm surrounded by an amazing team of people.
Do you have other surgeons here now that also do the breast cancer surgery? Are you the
I do. We have Dr. Angela Maslowski, who I hired 12 years ago. She's fellowship trained. And we just hired a third partner. She started 2 weeks, Dr. Angie Stork.
How about that? Yeah.
And she's, well, I'm getting old and I got grandkids, and the program is growing. And
Can't stop. You're good at what you do. Don't stop. We need you.
Yes, ma'am.
Please don't stop. Is it okay with Amy if you keep working?
Yeah, but there's a plan,
Okay.
We're just so busy, and I won't leave the program, because I think I have a lot to offer, a lot of experience and knowledge.
You do.
And so I will stick around for, while I'm 65. So, I'm as my friend JD says, I'm in the fourth quarter heading towards the 2-minute warning. So.
Listen, I think you've got a lot of overtime left in you. You're not.
Yes, ma'am. Well,
you got a lot of overtime.
As long as the Tigers don't go to overtime. But, yeah.
Okay. So I heard you say that you have to go to some meetings to stay on top of latest practices and best practices, right?
Correct.
So in the late 1960s, my mother had a radical mastectomy.
Right.
They removed all the breast tissue and muscle. So she was had a part of her chest that was just carved out. And I think she just wore something in her bra, like a prosthesis in her bra or something like that.
Right.
How has early detection, diagnosis, treatment, surgery, how has it changed since the 1960s? Because that's typically you just did either take the breast or the lump out. How has it changed?
Well, it's changed a lot, because what we found in the late 60s was that we initially thought that a radical mastectomy, which you described beautifully, and sometimes they would go on the chest to take the nodes, that didn't cure breast cancer. So at that time, we realized it was also a systemic disease, not a local disease. And so we started seeing more and more women with breast cancer. So we started a screening program like colonoscopies. And
Can I
so,
ask you a question? I'm going to interrupt.
Yeah.
So you said it was systemic. That means the cancer was going into the lymph system?
no, it could go to the rest of the body.
It's just anywhere. It can go anywhere.
Yeah, so because the surgery didn't contain it all. And
Okay.
so we learned a bunch from that. So one, we learned about screening. So we started mammography. And once you found a smaller tumor, we then did a clinical trial to show that it was safe to save a woman's breast with the lumpectomy, nodal staging, and radiation therapy. And that's kind of when we really started understanding about anti-estrogen therapy, like with tamoxifen and stuff. And then we started really getting into chemotherapy that could help. We also learned in that time, Kat, because we weren't screening, a lot of women would show up with locally advanced disease and that were inoperable. And so that's where we learned what's called neoadjuvant chemotherapy or upfront chemo. And we actually are specialized in some of that here now.
Can you repeat that word for me, please?
Called neoadjuvant chemotherapy,
Okay.
where you would do chemo before surgery. So you switch the order of things. And there's very specific indications for that today. And it's really nice to have some pretty clear guidelines, because 20 years ago when we started doing neoadjuvant therapy, it was based on clinical intuition and some pathological features. Now we look at really the biology of the tumor to determine what treatment is the best to do first. In some cases, fortunately, we don't need chemo, so they get their surgery and radiation and take their pill for 5 years and they do fine.
Is the pill the tamoxifen pill?
Well, that was the first one. And it's an estrogen blocker. Now for postmenopausal women, we use what is called aromatase inhibitors, and they stop the tummy fat from making estrogen. And estrogen is the primary hormone that drives 70% of breast cancers to grow.
Wow.
And so, there's side effects from those medications, of course.
So it sounds like the treatment is much more specific to the patient now.
So what I tell my patients, and every, like I've had 5 positives already this week, but you can't put all breast cancers in one basket. And the goal of our program is to find the individualized, tailored approach for each patient based on their biology, because the tumor biologies are different.
Okay.
Breast cancer is not a homogeneous disease. It's a heterogeneous and presents in multiple different, quote, subtypes. We have 4 or 5 major subtypes, but they can be further divided to other subtypes. And so that guides our treatment making decisions, particularly from a chemotherapy standpoint and even immunotherapy that we're using now.
So back in the 1960s, when my mom found her tumor, I mean, they found it by feel. They felt it. They felt that they would find it like that. We're much more using the mammograms now. Do you think we've gotten to the point where women understand the importance of the mammogram? Do we have
That's a great question, because we now use 3D. Traditionally, analog mammography would reduce risk by 25%. Mm-hmm. With the new 3D technique, which Titus was 3rd in the state 12 years ago to start, it reduces the risk by 40%.
Wow. Before
COVID came, the United States Preventive Task Force had all these new rules about not screening women in their 40s and doing every other year and quitting at 75. Mm-hmm. In certain patients, the problem is we don't know who those certain patients are. And then when COVID came and women weren't getting screened, we realized that a 2-year delay was bad. Mm-hmm. So, screening should be at 40 and every year, and there's no age limit to screening. And if we can truly find it earlier, it's much easier to take care of, and frequently don't have to use as much toxic therapies. But screening, and there's still a lot of misinformation about screening. And, part of the reason why we started our cancer walk, we just had our 19th walk and raised over $1 million so far. But it's so every woman in the Georgetown County area would have access to screening regardless of payer status, because early detection is truly important. And the only way you can do that is with mammography. You can use ultrasound to supplement or MRI, but the true screening for breast cancer is with mammography.
So, because I had family history of breast cancer, I was encouraged to start at age 35. And I've had my screening every year.
Right.
I think I've only had one callback. They just had to look.
You're lucky, Kat.
Only one callback?
Yeah, you're lucky.
Yeah, I am lucky. I keep waiting for it to happen.
Well, you know what though? When
What?
you look at risk factors, the number one risk factor for breast cancer is age.
Mhm.
50% occur after 65. The median age is 62, but the average is 65. And so for the task force to say we shouldn't screen women after 75, I mean, I see patients who are 83 years old that could whip me in pickleball. Why would we not?
Yes, they can. Yes, they can.
Maybe they couldn't handle dose-dense chemotherapy, but we need to take care of that subset of this population because they're still at risk.
Yes. So how do you get the word out to people who may not see the doctor as frequently as they should? Do you have messages in the ER? How do you get the word out? You can have a mammogram even if you can't pay. How do you get that message out?
Well, the hospital takes care of most of that, and a lot of it through the walk and the preparation for the walk and advertising for the walk. And then I do a bunch of stuff out in the community and have done. I do think we could do a better job of letting the community know that these are available. There's Access Horry County, which also takes care of the majority of the underfunded patients. And it would blow your mind the number of people that are underfunded now in our community and don't have access to care. And a lot of doctors are stepping up trying to help, but these patients won't even go to the visits. We'll pay for the visit. We'll get them transportation. And if they don't go, they won't go for their follow-up.
Is it out of fear that they don't go?
I don't know. I know that in my world, the breast world, we still see women who ignore lumps in their breast. And they think it'll go away. And then, a year later, it's growing through the skin.
Oh, God.
And no, this happens. I mean, this is 2024, and I still see that probably 10, 15 times a year. People just get strange things in their heads, and they think like if we do a biopsy, it's going to make it spread. Well, if that was going to make it spread, why would I stick a needle in it?
People think a biopsy is going to make a tumor spread.
Yeah, I get that almost every day.
Oh, no, a mammogram doesn't make your cancer spread. A biopsy does not make your cancer spread.
No, we've studied all that. And
yeah.
We know that core needle biopsies is a standard of care. Today, the three ways we image the breast are mammogram, ultrasound, and MRI. And we have the ability to biopsy under all three of those modalities. And we're the only facility in this area that does that. And so we do it's called a minimally invasive breast biopsy.
Right.
And the nice thing is about 80% are negative. So if it's negative, you don't need surgery on your breasts.
Right. So name the three ways that you do it again.
Well, it's mammographic, which is called stereotactic. We were third in the state to start that in 1996.
Okay.
I tell my patients I've been doing it for over a quarter of a century because I'm an old guy. And then we use ultrasound guidance. And then at times we use MRI guidance to do the biopsies.
Yeah.
And we do probably 700-800 a year. I mean, we do a lot of biopsies.
Well, and mammograms don't take that long at all. I'm always in and out for mine. Yeah. Let's see. Now, so you've talked about this some. I said, how does our local community highlight breast cancer awareness and celebrate breast cancer survivors?
Actually, there's quite a bit that goes on. We do the In the Pink Breast Cancer Walk, which is a huge event at Brook Green this year. Over 2,100 walkers, not including children. But it's amazing the number of restaurants, there's motorcycle groups. There's so many different places that do. There was the Prancers for Breast Cancer in Georgetown I spoke at. There's the North Santee Walk. There's a lot of different things that go on. It's almost too much for me to do because I get invited to attend those because I think they're important. I do think our community does a really nice job of raising awareness during this month.
I see a lot of women that have some nice T-shirts, or say something about the breast cancer walk, or these things almost killed me, or some funny things, some light ones, But I do see some T-shirts from time to time. But I think it's great.
It's important because it's really, except for skin cancer, the number one cancer in women in our country. It's the number one, besides skin cancer, it's the number one cancer in women. It's the number one killer of women by cancer in our state. I mean, the key is really early diagnosis and to get your screening mammograms. And, none of these modalities are totally perfect, but 3D has really changed the game here. And our radiologist, Robert Whitehead, and his group have done an amazing job learning how to read these things. And they're way ahead of the game because they started it 12 years ago when only about 30% of programs in the country were doing 3D, and we were doing a little old Georgetown, you know?
That's amazing. And
Well, it's the right thing to do.
it's the right thing to do, and it gives me a lot of great comfort. Okay, so just say I go for my mammogram and a lump's discovered in my breast. What's my next step after that?
Well, normally if you have an initial finding that's abnormal, they'll call you in for a follow-up, a spot compression view where they will magnify it and compress it. If it disappears, then they'll probably do a short-term follow-up.
Mhm.
If the abnormality persists, then they will do an ultrasound.
Mhm.
And if you can see it on ultrasound, you determine if it's solid or cystic. So if it's solid, then you're gonna need a biopsy, which could probably be done under ultrasound or mammographic guidance.
So, okay. And then if surgery is needed, then surgery would be scheduled after that.
The way we do it here is we get the referrals and we will do the biopsies. And if they're positive, then we actually do an MRI preoperatively. It goes in front of my tumor board. So it's a big discussion with the team so we can map out the appropriate plan for each patient.
So it's not like a haphazard decision. I'm going to cut this woman open, next week. You sit with a group of people, and
Oh,
it's
no.
very careful discussion for every single patient.
It's become as compared to when I was training in the late 80s, breast cancer is a very complicated disease. And in each case has a little bit different features based on the patient's individual biology. And it really helps guide us in our treatment making decisions. And so having the radiation oncologists and the medical oncologists and even our pathologists and radiologists all together in a room with the big screen TV where we look at everything. And the nice thing about my tumor board is that all egos are checked at the door. We're just all here for the patient. I'm not being cliche or being full of what, but I mean, it's all about what's the right thing to do. And so you can ask hard questions in our tumor board without anybody getting upset or offended, because sometimes you don't know. And so you need people's help. And that the heart and soul of our breast cancer program is my tumor board that I've been running for 20 years. It's just an amazing group of people.
Okay. How's your success rate? Is it getting better?
Well, everything's better. In fact, the last 20 years, we've had over 42% improvement in survival.
That's great.
And it's because of multiple things: early diagnosis, and then more targeted therapies and better understanding of the disease. So even our metastatic patients are living much longer. It's almost like a chronic disease, and they can live with metastatic disease 5, 10, maybe even 15 years. And when I was training, that would never have happened.
So let's talk about what that word metastatic means. So that means there is cancer inside their body and it might have moved to other parts of their body, right?
So it went from the breast to breast, number one place for breast is bone. Mm-hmm. So bones, lung, liver, and brain are the main 4 areas that breast cancer spreads to. Mm-hmm. And when it gets into your vital organs like your lungs, your liver, brain, those are emergent kind of situation, not emergent, but they're top priority because those are organs we need. Multiple bony disease is a little bit easier to handle because it doesn't affect our vital organs. But metastatic disease means it's spread outside the breast to other places.
So you can still keep those patients alive for a while.
That's what our medical oncologists do an amazing job at. I had a lady at the walk this year, and I mean, she was had very diffuse metastatic disease, one of my favorite people in the whole world. And she's just, her faith is powerful. And her last PET CT showed no active cancer.
Oh, that's amazing.
I mean, it's amazing. And the thing is, we shouldn't have to get to that point. Right. If we can get people screened, then we can really reduce the risk of metastatic disease. And that's really key. But there's a lot of hope, a lot of good things going on with breast cancer, and we're making a difference.
So I want to ask you, I just thought about this. Patients who pray, do they seem to do pretty well? The patients who pray?
Sure.
Do you see a difference? You don't know the difference? I don't know. That just came to my brain. I thought about that for just a second.
No, we pray with our patients sometimes, and we're in the South, so it's a pretty powerful faith area in our country. Mm-hmm. And it's not unusual. There's a lot of prayer warriors out there. Yeah. And that's a wonderful thing. That helps all of us.
Yes, it does. It's amazing. And I'm thinking about what's keeping a woman from going to have mammogram. And I'm thinking maybe if she would bring a friend, maybe if she would just go sit down and talk with the people that give the mammogram, just talk about what, even if she doesn't want to do it that day, just say, what's going to happen to me if I come in here?
Well, I think access is still an issue. Transportation is an issue.
Transportation, yeah.
And I think that they're afraid. You know, I mean, the anxiety levels can be pretty high, particularly if you're feeling something in the breast. And it's, you know, I wish there was a better way that we could really access. I would love for everybody, the whole dream when we put the walk together was so that no woman in Georgetown County would go without mammography. I'm not a socialism medicine kind of guy, but every woman in the country should be allowed mammographic screening.
I agree.
That was something we should do, and we could do it. It's not like the radiologists make a bunch of money off of reading mammography, because they don't. And it's a very difficult thing. It's like looking at, you know, we do, I don't know, 25 or 30,000, maybe more than that, but every mammogram is different. You know, it's not like they're all the same.
Yeah.
And there can be real subtle stuff that goes on the breast. You know, a 5-centimeter tumor doesn't come up over a week. You know, it takes time. And so you have to compare old images and stuff like that.
We don't have a mammography van or mobile mammography in our county yet, do we?
No.
Is that a goal?
Yeah, I'd have to talk. Yeah, that would be a great thing to do. You know, Dabo's got 3 of them up in the upstate. So
That's
maybe
right. So that's leading to my next question. You and your family have very deep roots at Clemson. So I would like for you to talk about the roots that you and the Brackett family have at Clemson. And I want you to tell our listeners what you've done now up there with Dabo's All In Foundation to help that effort.
Well, so my great-great-grandfather was a founding chemistry professor
At Clemson.
At Clemson, 1896. And then from 1911 to 1933, he was chairman. So they call it the Ology building now is Brackett Hall.
Brackett Hall.
And then his son, my grandfather, went to Clemson and went to MUSC and was a family practitioner in Pickens. And then my dad went to Clemson, MUSC, and then became the first nephrologist in the state of South Carolina. And then I went there, and then all 3 of our kids went there. So it's in our blood, and it's not just about sports, you know. We actually have I'm part of an endowment fund that I helped start for scholarships for physicians for young students. And then we do something called Tigers on Call, which is a mentoring program. And they call us the Fab Five because there's 5 of us that got involved initially. But it's the College of Science and Health Science that does out there. And we're on our 11th year now. And it's a 2-day event where you can, like, we teach kids how to suture. And then we have roundtable discussions and we have breakout groups. And we've actually had 3 students come stay with us, and they would shadow me. And
wow.
And that's really that's an amazing, fun couple of days. And like
Go ahead.
One of my students I'm really close with, he's getting married in April, so we're going to the wedding.
Exciting.
And he comes by tailgate and all that kind of stuff. But it's a really wonderful experience and very fulfilling when you spend those time with these. Makes you feel secure about the future that you have young people that are interested in doing what we do, you know.
So let's talk about Tigers on Call. Is that an organization? I mean, so the students access Tigers on Call? Is that correct?
Well, it's run by the Health Sciences.
Okay.
And, Dean Young and Harlan Williams are 2 of the biggest ones involved in that.
Uh-huh.
And it's kind of evolved over the last few years. Now we have some CME for the physicians in the morning, and then we have these 30-minute roundtables where the students can come and talk to there's all kinds of different doctors, you know, surgeons, medical oncologists, internists, family practice, GYN, ER.
So is it like an event?
It's a huge event. We have over 250 kids come.
How many days does it take place? Is it 1 day, 2 days, 3 days?
It's 2 days.
Okay.
And so It's one of my most favorite things that I have the privilege to do. And we had a young lady down here early this year, and she did medical oncology, surgery, and saw some radiology stuff.
Very cool.
And lit a fire.
I love that. So let's talk about what you do with Dabo's All In Foundation, and tell our listeners.
I just get to go.
You just get to go. You must have made a donation or something.
No, I just get to go. Now, my wife goes is the women's program that he and Kathleen do is the real big one, where they raise about $500,000 every year.
The ladies' clinic.
The ladies' clinic, and that's an amazing event. I've never been, obviously, but Dabo and Kathleen have not only put out all these scholarships upstate and around the state, but they have 3 mammography buses.
Right.
And that go around and help take care of underprivileged folks.
With the mammograms.
Yep. And get them.
I believe Dabo's wife, Kathleen, she didn't have breast cancer, but her sister died from breast cancer. Is that correct?
That's correct.
So then a woman can go and have a test or screening to see if you have the gene for it. Is that correct?
So we have just actually hired a genetic counselor at Tylen's. And the National Comprehensive Cancer Network guidelines that we use to determine whether a patient should have genetic testing. So it's a blood draw or a saliva test. But just for the purpose of your podcast, the big ones are breast cancer at an early age, ovarian cancer, pancreatic cancer, and then the GI cancers. So breast, ovarian, and an early prostate cancer with metastatic disease. I saw 3 African Americans in the last week with BRCA2, which is one of the initial breast cancer genes. And normally that was found in Ashkenazi Jewish heritage people. But there's actually about 10 or 11 different genes that increase your risk for breast cancer. But we have whole panels that we do now that can look for breast, ovarian, GI, pancreatic, thyroid, and so it's just a simple blood draw, and it can help. And we use it all the time because it helps me make recommendations on how we follow patients based on not only their genetic makeup but their other risk factors. But you got to understand that 70% of women with breast cancer don't have a family history. And
wow, you're kidding me.
No, and then 20% have this familial cluster, but no gene mutation. They'll be at moderate risk. And then like 10% carry some kind of mutation. And the BRCA1 and 2 are the ones that have the higher propensity to cause breast and ovarian cancer. And so it really helps us understand how we will screen patients, depending on the age they're found. A 40-year-old would get MRI every 6 months with mammogram. A 75-year-old probably who's got a fatty replaced breast doesn't need MRI because she's at 75. That gene did not, cause a cancer, right? And so, but we had just hired. She's a delightful young lady. Wanted to come to a small community. Courtney Davis is amazing, and we're really lucky to have her because I'm not a genetic counselor. I know, and it's really complicated when you look at the NCCN guidelines about who meets criteria. It's like,
So what I was talking about earlier with Dabo's wife, she took some kind of genetic test, determined that she had the gene, and then she decided to have a mastectomy. Is that correct?
Yes.
So you can have your breast taken off and then have reconstructive? Is that what they do?
Right. And we do that some. Initially when these genes were discovered, the patients would present with advanced tumors that were node positive and were triple negative, which is an aggressive form of breast cancer. So once we first identified the BRCA1 and 2, we would automatically recommend bilateral mastectomies. And that's a pretty big deal for a 35 or 40-year-old.
It is. It's a very big deal.
So, but now we have ways with prevention, chemo prevention, MRIs, and ways to follow patients because it's only a 40 to 70% chance in your lifetime. So it's not 100% penetrance, as we say. And so I have quite a few patients, and we'd like to sign a contract. You will come to your mammogram, you will get your MRI, you will check your breasts every month.
You're doing this for the patients who have the gene.
who have the gene.
Okay.
And and that's what we do, because we also, not only do we treat breast cancer, we treat benign breast disease, but we also run a high risk clinic. Risk is, age, breast density, family history. If you had an atypical biopsy, obesity is a huge thing. Today in our country, it's the #1 cause of cancer death in the United States.
Obesity is the #1 cause. So being overweight is the #1 cause of breast.
Well, it's going if it's not there, it's going to replace lung cancer soon. Obesity associated endometrial, colorectal, gastric, pancreas, renal, and breast cancers. And in the breast world where I live, women who have a higher BMI make more estrogen. And we're also living longer. So there's a longer period of time for the estrogen. Once your ovaries are gone or quit working, you keep pouring estrogen into the breast tissue. And estrogen is a primary driver to make these things grow and divide. If you stimulate a precancer cell to grow and divide, it eventually will become a cancer. Obesity is a huge problem for recurrences. I had a patient, she had a 5-centimeter mass in her breast and was so obese that she could not have chemo before surgery. So we put her on an anti-estrogen medication, but she lost 100 pounds in like 3 months. The tumor disappeared. And it wasn't the pill I put her on, because it's the tortoise that wins the race. It doesn't work that fast. But she lost 100 pounds, and the tumor went from that to nothing in 3 months.
So you did not have to remove that tumor?
Well, you still got to remove it, because you got to prove pathologically that it's all gone. I mean, She still got a lumpectomy and radiation.
Right.
But
so are we saying that cancer feeds off fat?
no, it feeds off the hormone that fat makes.
Oh, the hormone. Okay.
So, like, I can get real technical here, but your adrenal glands make a hormone called androstenedione, which is what Sammy Sosa and Mark McGwire were taking when they were trying to beat Hank Aaron's home run.
Yeah.
So your adrenal glands make that. Your tummy fat converts that hormone, androstenedione, to estrogen. So the more tummy fat you have, the more estrogen you make. And then so estrogen stimulates the ductal cells to grow. And so we have a drug called aromatase inhibitor that we use in postmenopausal women to stop that from happening. But obesity is a huge problem, and I'm not even going to begin to get in our diets, because what we allow in our food here is terrible.
And you're talking about the United States?
United States, Europe doesn't allow none of that stuff.
Is it the preservatives, you think?
No doubt.
Okay. So it's, eat as fresh of food as you can. Fresh.
As my bride says, as many colors on your plate as possible without food dye.
There you go. Okay. Wow, that's a lot.
Yeah, it is. We could go for a couple hours,
Okay, I'm gonna get back to your personal life. Is there anything, any items on your bucket list that you would like to do that you haven't done yet?
Oh, wow.
I know, do you still ride your bike a lot, or ride?
No, it's too dangerous to ride here. There's too many people. I ride my Peloton a little bit. I want to travel a little bit. I want to see. I'm infatuated with the American Wild West, and this country is so beautiful. I would like to see Yellowstone and Bryce and all those places, and stuff like that. I think that I love being out there.
It's amazing. Like, if you see a map of the United States that's taken from space, where they're showing the lights and how the light is so concentrated on the East Coast, Midwest, and then in California area, but nothing in the middle of the country still. It's amazing.
Yeah, that's where I want to go.
Yeah. Well, I hope you get there. Do you have any messages for our listeners, or to your family, or personal message to your family?
Well, no, they know I love them dearly, but I just I appreciate the opportunity. I think I've done this for many years. I think that to get the message out is really important. I think screening really saves lives. It sounds so cliche, but I deal with it every day in my office, and it makes such a huge difference. And we have ways to get our folks screened, and to not be afraid. If you feel a lump, just call the office and we'll do an ultrasound, let you know if it's okay or not, because you're going to feel lumps, but I just wish the patients would come in and get their screening so we could care for them.
Craig, do you have a phone number that I could tell our listeners to call? I'm going to write it down. Do you know what it is?
No, because if I give out my office number, they would shoot me.
Okay, well, you know what? I'll figure it out. I'll figure it out.
I think it's 1-800-Tidelands, or called Tidelands Docs or something.
Okay.
Fine Doc.
I'll figure it out and I'll let people know. But gosh, thank you for saving so many lives and keeping so many of my friends alive. I really appreciate it. You've done a great job. And, it's gone from where women are so afraid that they think it's a death sentence to, wow, I'm going to live 20 and 30 more years. So, which is,
we can make a difference, and they're doing great. I really appreciate this opportunity. Thank you so much.
Thank you so much. I look forward to seeing you around town, and I hope Clemson wins the rest of their games.
Me too. God bless you. Thank you, Kat.
Bye.
Bye-bye.
Let's see here. I'm going to end this recording.
Hello.
We hope you enjoyed episode 37 of A Slice of Pie podcast with Dr. Craig Brackett. He really knows everything there is to know about early detection, treatment, and surgery of breast cancer. Breast cancer is important to me. Our mother had it when I was a very young girl back in the late 60s. She lived for a long time, though, after her breast cancer surgery. But the treatment and care of breast cancer patients has improved so much since our mother had breast cancer. So please remember to get your mammogram every year. I started when I was 35, and I go every single year. It doesn't take very long to have that done. And if you have to have a biopsy, that doesn't take very long either. Don't be afraid. If you are afraid, just take somebody with you, but there's nothing to be afraid about. They'll take very good care of you. So Dr. Craig Brackett's office is up in Murrells Inlet, South Carolina. You can just look him up, Google him. On your phone or on the internet, you can find him. He's with Tidelands Health. He does a great job, and he has other physicians that he works with too up there, and has a whole team that he works with to work on your case if that's something that you're diagnosed with. We hope you're doing well in Pawleys Island as we just left Halloween and we're heading toward the holiday season. So we have lots to look forward to in the Low Country. We're doing well down here. We didn't have any storms, so come down and visit us. We'd love to see you down here and host you. Lots of fun things going up. I hope to next interview some people that are decorating the Kaminsky house for the holiday season, so stay tuned for that. And until then, take care and have a great week. See you soon. Bye-bye.